colorectal cancer screening. Mushroom season. The giant butterflies are mating. The dank smell of dung is in the air, and it's time to start picking. Don't you just love it? Unfortunately, Papa Polypet has to take a break from shroom grooming today, as he's on his way to Doc Polypet for an annual checkup. Nothing's really wrong, and he takes all of his medicines. But he wants to be careful because, let's face it, he's getting a little older. In the office, Doc Polypet finds a gentleman in perfect health and a good mood. They had a nice chat about Papa's father, who is doing well. Doc remembers that Papa's father was diagnosed with lung cancer at age 64. On review of his chart, Doc Polypet notes that Papa had a colonoscopy 4 years ago, at which time a polyp was removed. At the time, the polyp was noted to be 8 millimeters in size, had high-grade dysplasia, but no lymphovascular invasion. And it was completely removed, so he's fine, right? I can't think of anything we need to do for Papa at this time. Just refill his blood pressure medication and...
No, that's not it.
Wait, what? We're not done here? Aw, how come?
You literally just said it.
The high-grade dysplasia? Yeah, something is a bit fishy with that, right? Well, you're probably right. Let's look more into this. We certainly don't want to miss something that could prevent Papa Polypet from developing colon cancer. Cancer is always a scary word to patients. But colon cancer, if caught early on, is very treatable. Unfortunately, however, colon cancer is the second leading cause of cancer deaths. So the U.S. Preventative Services Task Force, or USPSTF, came up with guidelines for colon cancer screening based on strong scientific evidence. Per the USPSTF guidelines, routine colon cancer screening should always begin at age 50, or if there's a family history of colon cancer, should start 10 years before the age at which the youngest relative developed colon cancer. So, Papa Polypet from our clinical case, who has no family history of colon cancer, is riding high on those 5-0 tires. This family, on the other hand, who had a grandfather that developed colon cancer at age 57, is riding on a beetle with opportunely placed red markings to form a -10 to remind you that screening starts 10 years prior to the age at which colon cancer was developed in a relative. So this means screening colonoscopy should start at age 47 for the dad of this little Polypet family. Screening endoscopy should be repeated at regular intervals, depending on what modality is used, of course. For colonoscopy, which is the gold standard, the recommendation is to screen at least every 10 years starting at age 50, though some patients will require more frequent scopes, depending on the findings in each colonoscopy. More on that later. So, Papa Polypet, well, he didn't quite get his colonoscopy at exactly age 50. He got it at 54, so his next one should be at 64 by these guidelines. Right? Or am I missing something still? Here you'll notice this butterfly, who besides being beautiful, or whatever, is a helpful reminder of colonoscopy frequency with that big Roman numeral 10 flapping around on his wings as he flies over the screen around the flower to stick his proboscis into the orifice of that flower. So, every 10 years? Not that much of a pain in the ass. To perform colonoscopy, a flexible fiber optic endoscope, much like this one, is used. Suffice it to say, very few, if any, patients complain about the overpriced lubricant on the final bill. I guess sometimes you appreciate what you pay for. The endoscope is inserted into the patient's anus and advanced the entire length of the rectum and colon, a distance of about 180 centimeters, or in more familiar terms, 1.2 Danny DeVitos. The splenic flexure, at the end of the transverse colon, is a difficult turn to make with the endoscope. If you stop short and only examine the left colon, no problem. But in this case, it's called a sigmoidoscopy. Sigmoid colon, sigmoidoscopy. Not a far stretch. Pun intended. Sometimes stopping at the splenic flexure is the goal, though. Sigmoidoscopy alone can find more than half of all polyps, since the majority of colon polyps occur in the sigmoid colon. Much like most of the mushrooms are growing around the sigmoid-shaped section of this path. And then it avoids that technically challenging and sometimes painful for the patient turn past the splenic flexure. Sounds fantastic, right? There is a downside, though. Given that sigmoidoscopy only visualizes half the colon, it's no surprise that the time between screening recommendation for sigmoidoscopy is half the time between colonoscopies. But it does make it easier to remember. Half the length, half the time. Our butterfly with the Roman numeral 5 reminds us that this is every 5 years. As an alternative to colonoscopy, the recommendation is for sigmoidoscopy every 5 years in combination with guaiac fecal occult blood testing, or FOBT, or fecal immunochemical testing, or FIT, every 3 years. Our butterfly's little friends with the 3 on their wings, taking breaks on the matchbooks, are reminders that FIT and FOBT testing should happen every 3 years in combination with sigmoidoscopy. Don't ask me why a gym is passing out matchbooks, though. Uh-oh, this looks like it's going to get even more complicated. Another alternative, sigmoidoscopy can be spaced every 10 years if combined with annual FIT testing, hence the X-winged butterfly and annual birthday cupcake. Happy birthday? No, thank you. In any case, colonoscopies, and sigmoidoscopies, for that matter, are invasive and sometimes stressful, most often requiring at least some anesthesia. This physiologic stress and need for anesthesia makes invasive endoscopy dangerous for some patients, i.e. severe CHF, end-stage renal disease, etc., which leads to a problem. How would you look for polyps if your patient can't or won't tolerate invasive procedures? If a patient is completely unable to undergo lower endoscopy in the first place, e.g. severe CHF, anatomic difficulty, or just flat-out unwillingness, other, albeit less sensitive, methods of screening are available. The traditional two are contrast barium enema and CT colonography. However, due to its poor sensitivity, double contrast barium enema is no longer recommended as an alternative to colonoscopy, though it may still pop up on test questions. If colorectal screening is performed by CT colonography, it should be done every 5 years starting at age 50, which is why Happy CT Kitty is chasing that V-winged butterfly. Ugh, good luck, little fella. Well, he's just a little guy. Sorry. I enjoy cats. Oh, I'm so alone. Anyway, if your patient can't get a colonoscopy, sigmoidoscopy, or CT, maybe they live in the middle of nowhere, or can't tolerate any contrast, or think cameras will steal their souls. Annual triplicate, as in 3 samples, like these 3 matches from the guy's matchbook, guaiac-based fecal occult blood, or single-sample fecal immunochemical testing, aka FIT testing, can be substituted. Both are performed by placing a small stool sample between 2 slides and mailing it into the lab for microscopy. So, really seems to fall into that no hazardous materials category on the signs at the post office. Anywho, why so many screening modalities for colon polyps? Well, most colon polyps are adenomas, which are benign but have the potential to transform into carcinoma over time. Let this big plus sign remind you that adenomas are the most common polyp type. You know, add, like, addition, from, like, math. Yeah. Turns out the vast majority of polyps, especially the smaller ones, are completely asymptomatic nubbins on the colon wall. If they do cause trouble, adenomatous polyps most commonly present with painless bleeding, i.e. melena or hematochezia, based on their location. If large enough, they can cause stool caliber changes, especially sigmoid colon polyps. But again, symptoms are rare. They usually just sit there, taking up space and slowly progressing towards malignant transformation. What's all this fascination with 10 years? Well, it turns out it takes about 10 years for polyps to undergo the adenoma to carcinoma transformation. So the challenge to physicians is to seek and destroy polyps before they have time to complete the metamorphosis. Now that we've looked at when and how to go hunting for polyps, we need to think about what we do when we find them. First off, morphology plays a big role in asymptomatic colon polyp removal. Polyps can be flat and wide, aka sessile, or more commonly, protruding into the lumen as a mass on a stalk, aka pedunculated. The difference is almost identical to the 2 varieties of mushroom we have growing here. One is wider, remaining flat, and the other is reaching for the sky. The other terms regarding morphology are tubular and villous. Tubular adenomas are gentle little guys. They're the least likely to transform into cancer. They're typically pedunculated and are easy to treat. Villous is the other morphology type, and these are bad actors, like this villain sneaking around the house trying to steal mushrooms. Villus adenomas have a high rate of malignant transformation and are typically sessile and are associated with the highest rate of morbidity and mortality. Tubulovillus is a term also used and describes an adenoma that has features of both tubular and villus adenomas. When a pedunculated polyp is seen along the highway to smell, it can usually be removed using the scope and snare polypectomy. To do this, a wire loop is deployed from the end of the endoscope and passed over the polyp tissue. The snare is pulled tight and the polyp is cut off the colon wall. You may hear the terms hot and cold to describe the snare, which only describes whether electrocautery, i.e. bovie, is used. But don't worry too much about that. Important point, don't pull nearly as hard as this little guy here, or it won't end well. Sessile polyps, especially small ones less than 2 centimeters, are commonly removed using snare excision as well, though it's technically more difficult. In some cases, saline is injected into the colon wall to raise the flat polyp tissue and make snare excision easier. Unfortunately, sometimes they're only partially removed or can't be removed at all, and this complicates things. We'll come back to that in just a little bit. Let's remember way back to the beginning to our clinical case. Yeah, it's been a while since we talked about Papa Polypet. Remember his pathology report? It said that the polyp was completely excised. Okay, that's all I wanted to mention. So you've removed a polyp. Now what? Well, it all depends on the histology. Here we're going to learn about all those weird terms that were on the pathology report in the clinical case stem. As we mentioned, most polyps are benign adenomas. By definition, adenomas have a specific degree of dysplasia and are considered either low or high grade. As long as the adenoma has only low-grade dysplasia, that polypectomy you performed is sufficient treatment. This is the most common scenario, and you may see this referred to as benign adenoma. If an adenoma has high-grade dysplasia or carcinoma in situ, also known as CIS, you need to check the margins. If the margins are clean, polypectomy is sufficient treatment here too. Great. Papa Polypet from our case had a polyp with high-grade dysplasia. But heck, the margins were negative. Yeehaw! We're good to go. Or are we? What if the polyp contains invasive cancer, symbolized by this little beetle here? Whoops! Watch out there, big fella. That's no simple mushroom you're harvesting. If the cancer is confined to the polyp, there are some cases where polypectomy is sufficient treatment. The cancer must have at least a 2 millimeter margin, be well differentiated, and have no vascular or lymphatic invasion. Basically, small and well behaved. The majority of polyps that meet these criteria are pedunculated because that 2 millimeter margin can include the stalk. However, it is possible to get an adequate margin with a sessile polyp. It's just less common. A cancer that doesn't meet all those small, well-behaved criteria, like the scary-looking beetle here, will require surgery. At the very least, a segmental colectomy. This includes any poorly differentiated cancer, even if it's confined to the polyp and has adequate margins. Of course, any cancer that has invaded out of the polyp will definitely require surgery. Remember, the cancer must be confined to the polyp and have 2 millimeter margins in order to not need surgery. Most polyps can be resected completely with an endoscope. However, if complete resection of a polyp is not possible, like these incompletely harvested mushrooms with some leftover remnants of the cap still there, surgical resection may be necessary to remove the rest, regardless of the histology. This sometimes occurs with large sessile polyps. It's also more common for polyps in the right colon since it's more difficult to reach endoscopically. So, for Papa from our clinical case, it doesn't sound like surgery is the answer for him. Remember, he didn't have any cancer. He just had high-grade dysplasia and the polyp was completely excised. There aren't any remnants that would require us to resect some colon. So, we've removed some polyps and nothing is pushing us to do surgery. What next? Are we really going to wait a whole 10 years before checking again? The frequency of the colonoscopy screenings changes after a patient has been found to have polyps on screening colonoscopy. Certain findings on colonoscopy make it more likely for a patient to develop carcinoma, and so these patients should be followed up more frequently. If the patient has 3 or more benign polyps, a single polyp over 1 centimeter in size, or any polyp with high-grade dysplasia or villus morphology, they should have a follow-up colonoscopy in 3 years. These features make it more likely that the patient will return for that colonoscopy and have more polyps or even cancer. Well, I think we have our answer for Papa Polypet from our clinical case. He only had one polyp removed, and it was completely removed. But it had high-grade dysplasia, which means that he should have had a colonoscopy 3 years after the first one. So he's 58 now, and the first colonoscopy happened when he was 54. So colonoscopy for Papa Polypet it is. However, if a patient has a colonoscopy where polyps are removed that don't meet those above criteria, 3 or more benign polyps, 1 polyp greater than 1 centimeter, or any polyp with high-grade dysplasia or villus morphology, then that patient should have a follow-up colonoscopy anywhere from 5 to 10 years. Lastly, if the patient has more than 10 benign polyps, repeat colonoscopy should be performed way before 3 years and the possibility of a familial syndrome considered. But don't worry, much more on that later. So to recap. Get it? Cap. Like mushroom cap. I'm hilarious. All right, to recap, here's our summary. Colon cancer is the second leading cause of cancer deaths. However, it's very preventable, and if caught early, it's very treatable. So, surveillance guidelines were developed by the U.S. Preventative Services Task Force to detect polyps early. Adenomatous polyps typically transform into cancer over 10 years in the general population. This changes for familial syndromes, which are not a focus of this discussion. All individuals should have screening colonoscopy every 10 years starting at age 50, or 10 years before the earliest relative's diagnosis of colorectal cancer. Sigmoidoscopy every 5 years with FOBT or FIT testing is an invasive alternative to colonoscopy, or sigmoidoscopy every 10 years with annual FIT testing. Non-invasive screening may also be accomplished with CT colonography performed every 5 years starting at age 50. In the past, double contrast barium enema was an option, but is no longer recommended. Last and least invasively, annual triplicate fecal occult blood testing may be used in place of colonoscopy. Quick caveat: any abnormalities seen on screening tests other than colonoscopy are going to require a colonoscopy anyway. So why not just go for colonoscopy in the first place, eh? Moving on. The most common polyps seen are adenomatous in nature. These are typically asymptomatic, but in rare circumstances, may cause melena, hematochezia, or stool caliber changes. Polyps can be either sessile or pedunculated. Polypectomy is removal of a polyp, usually performed by snare excision during colonoscopy. Polyps that are completely removed and have low-grade dysplasia or high-grade dysplasia with negative margins are considered to be sufficiently treated. If invasive carcinoma is present in the polyp, it is still sufficiently treated by polypectomy only if the margins are greater than 2 millimeters, there is well differentiation, and there is no lymphovascular invasion. Surgery, by which we're referring to segmental colectomy, is indicated when there are positive margins of high-grade dysplasia, or if there's invasive carcinoma with margins less than 2 millimeters, poor differentiation, or presence of lymphovascular invasion. Incomplete polyp resection is another indication for surgical resection. After successful removal of the polyps, the frequency of future colonoscopies depends on the histologic features of the polyps. If there are 3 or more polyps, even if they're benign, or if there's a single polyp greater than 1 centimeter, or if there's any polyp with high-grade dysplasia, colonoscopy should be repeated in 3 years. If there are less than 3 polyps, none are larger than 1 centimeter, and there are none with high-grade dysplasia or carcinoma or villus morphology, then colonoscopy may be repeated in 5 to 10 years. Familial syndromes associated with colon cancer have a different set of guidelines not covered in this sketch. Everything we've covered here is really best-case scenario. For what to do when invasive carcinoma is found that isn't treated with colonoscopy, head on over to our colon cancer sketch. Can you just smell those flowers blooming? That was more colonic than I was expecting.